Dr. Ruth Orebiyi is the head of Public Health Division of Pharmacy Department at the University of Uyo Teaching Hospital. She supervises obstetric and gynecology pharmacy team on ward rounds in UTH. She is the PRO of CPAN Akwa Ibom State. She's a distinguished pharmacist. She's actually the Deputy Director of Pharmaceutical Services in the University of Uyo Teaching Hospital. And she's well-read, very experienced in hospital pharmacy practice and as well as administration. She's a lover of clinical pharmacy and also has an interest in public health pharmacy. She has a number of studies that is anchored on promoting clinical pharmacy and clinical pharmacy practice. So let's welcome Dr. Paul Orebiyi as she leads her team to present this topic. Hello, Ma. You have the floor.
Okay, good evening, everybody.
Good evening, Ma.
Good evening, all PSN ESCO executives present, CPAN National ESCO, and all our distinguished colleagues, ladies and gentlemen. Tonight, we will be talking about postpartum hemorrhagic events. And suffice it to say that in the medical world, a lot of attention has been paid to it by the physicians, by the nurses. Interventions and strategies have come up in those areas. But we see as a team the need for clinical pharmacies to create impact in that area or in the area of management of postpartum hemorrhagic events. So that is going to be the focus of tonight's discussion. We have a team, like he mentioned, a team of hospital pharmacists and a community pharmacist that, did this study, and we came up with this presentation. At the end of the presentation, we'll run through a brief case study to, illustrate what we are talking about. Thank you very much. My name is Dr. Ruth Orebiyi. Okay. Please, Dr. Onyeme, make Nsikan Udofia co-host so that he can post the slides.
Sorry, I'm not the admin in this, so I don't know if...
Okay, CPAN National, please make
Nsikan Udofia.
Yes. Make Nsikan Udofia the co-host so he can post the slides. Thank you. Please, who is holding on for CPAN National?
Please.
Okay, yes, Nsikan Udofia is a co-host.
Okay, so he can start to post the slides.
Okay, please. I hope it's in PDF because I tried to share. It's not in PDF. If not in PDF, it will not go.
Okay. Isikan, you can start slide sharing, please.
Like Sika is disconnected. I can't find Sika again. Okay, Ma, can you continue?
Yeah, I'm trying to. Do I send the slides to you?
It has to be a PDF.
Please just hold on. Start from the first one.
Hello, Ma.
Why is it not showing? It's supposed to.
I think Isika is back. So, okay.
I don't know why it's not showing. Is it not showing?
Presenter, you can start. So while we wait for the slides, time is almost 9:30.
Yeah, I think so. I would think so.
Allah maɗaukakin sarki ya turo wato na bakona ya arba.
Okay, good evening, everybody. I'm so sorry for that hitch. We had a problem. So we are talking about postpartum hemorrhagic events, and our outline is as posted. Can you see the slides? Hello, can you see the slides?
Yes, we can see the slides. Yes, but it's not. It's okay. Yeah, we can see the slides.
Can you see this? Okay. So we are talking about postpartum hemorrhagic events, and our outline is as posted. It's not launching.
Please, what's happening again?
Presenter, please, can you continue, please? People will start leaving.
Okay, so I'm sending the slides to Dr. Bello to screen share for us. Okay, so that's our outline is as posted, and by introduction, hemorrhagic events are common, though largely undiagnosed. An obstetric hemorrhage is the most common and dangerous complication of childbirth. We have 3 types of hemorrhaging events. We have bleeding before 24 weeks of pregnancy, which is regarded as a miscarriage. We have obstetric hemorrhage, which is bleeding from the birth canal after the 24th week, which can occur anytime until the 2nd stage of labor is complete. And we also have postpartum hemorrhage, which is bleeding following the birth of the baby. Postpartum hemorrhage. Postpartum hemorrhage, PPH, is an obstetric emergency and one of the top 5 causes of maternal mortality. Timely recognition, availability of appropriate resources, provider institutional planning and preparation are appropriate responses which are critical for preventing death and severe maternal morbidity. Common symptoms of PPH are bleeding, dizziness, feeling faint, and blurred vision. Definition. Primary or early PPH refers to PPH occurring in the first 24 hours after giving birth. Secondary, late or delayed PPH refers to PPH occurring from 24 hours to 12 weeks after birth. The American College of Obstetricians and Gynecologists revised definition of PPH in 2017 to include cumulative blood loss greater than or equal to 1,000 mils, bleeding associated with signs and symptoms of hypovolemia within 24 hours of the birth process. And these criteria appear applied to both vaginal and cesarean deliveries. Criteria for diagnosis. When diagnosing PPH, we need complete medical history, physical examination, and symptomatology with appropriate tests. When bleeding is greater than expected, with signs and symptoms of hypovolemia, or the presence of hypovolemia in absence of excessive blood loss, which may reveal, bleeding, which is concealed, maybe bleeding in the intra-abdominal, retroperitoneal, or in the pelvic floor. Please, I hope you're seeing my slides. Hello, are you seeing the slides?
Yes.
Hello, are you seeing the slides?
Yes, you can see the slides, although it's a bit small.
In classification of postpartum hemorrhage, we can classify it based on severity, and there are 4 stages, which may be used in classifying the severity of PPH. You have stage 0, which is a stage for every patient in labor or that is giving birth. And interventions include administration of prophylactic oxytocin, quantification of cumulative blood loss, and close monitoring. Stage 1 involves cumulative blood loss greater than or equal to 500 mils at vaginal birth, or greater than or equal to 1,000 mils at cesarean birth, with continuous bleeding or signs of concealed hemorrhaging, where vital signs are abnormal or trending in that direction. Oxygen saturation less than 95%, shock index 0.9, or confusion. Where you have these features, interventions include activation of institutional PPH protocol. In stage 2, there's continued bleeding with vital sign instability and cumulative blood loss less than 1,000 mils. Interventions are to begin next level of interventions in institutional PPH protocols, mobilize PPH rapid response team, and blood bank support. For stage 3, you have continued bleeding with cumulative blood loss less than 1,500 mils, or transfusion with greater than 2 units of red blood cells, with abnormal vital signs, or suspicion of disseminated intravascular coagulation. Intervention is to move on with the next level of interventions in institutional PPH protocols, initiate massive transfusion protocol, and surgical approaches for control of hemorrhage. Another classification for PPH is the advanced trauma life support classification. The first classification was based on severity. This other one is based on the advanced trauma life support, where, in class 1, you have blood loss estimated at 15%. You have heart rate is minimally elevated or normal. Blood loss, in class 2 is between 15 to 30%. Heart rate is 100 to 120 beats per minute. Respiratory rate 20 to 24 breaths per minute, and decreased pulse pressure. In class 3, you have estimations for blood loss 30 to 40% with a significant drop in blood pressure and changes, in mental status. For class 4, you have blood loss estimated at greater than 40%, leading to significant depression in blood pressure and mental status. Most patients here have systolic blood pressures less than 90 millimeters hydrogyrum, with pulse pressure less than or equal to 25 millimeters hydrogyrum, with marked tachycardia greater than 120 beats per minute. Urine output is minimal or absent, with cold, pale, clammy skin, and capillary refill is delayed. Epidemiology. Why are we talking about postpartum hemorrhage? You see, most of the reports are based on estimates of blood loss. However, when blood loss is measured quantitatively, prospective studies have reported postpartum blood loss greater than or equal to 500 mL in as many as 10% of the beds. We also, from reports, know that every day in 2020, almost 800 women died from preventable causes related to pregnancy and childbirth. A maternal death occurred almost every 2 minutes in 2020. And 60% of maternal deaths in developing countries are due to PPH, accounting for more than 100,000 maternal deaths per year. And you know that Nigeria is among these, developing nations. Etiology. Most times when you talk about PPH and causes, the 4 T's are used. The 4 T's refer to thrombin, tissue, tone, trauma, and others. But essentially, the cause rotates or revolves around the 4 T's. Thrombin may be due to preeclampsia, placental abruption, pyrexia in labor, bleeding disorders, anticoagulation, von Willebrand disease. Concerns about tissue are related to retained placenta, placenta accretia, retained products of conception. When you're talking about tone, the concerns are related to placenta previa, overdistension of the uterus, multiple pregnancy, polyhydramnios, microsomia, uterine relaxants, and then previous episodes of PPH, maybe in previous pregnancies. For trauma, you have that cesarean sections, episiotomies, and microsomia for babies greater than 4 kg are indicted. Other causes, it may relate to Asian ethnicity. It's not, about the physique or the structure, but most times, or rather implication, boils down to the quality of care in those countries or those regions. Anemia, induction, BMI, greater than 35, prolonged labor and age are other contributory factors. Okay. Pathophysiology, has to do with a complex interwoven indices involving, reduction in blood supply, reduction in oxygen supply to organs and tissues. Also, you have to talk about possible ischemia, and then you also have lactic acidosis, and then, of course, tissue death. That is what the pathophysiology of PPH revolves around. What are the signs and symptoms? Each estimated percentage of blood volume loss is associated with some signs and symptoms. Where you have 10 to 15%, 500 to 1,000 mL, you have systolic blood pressure may be normal, but with signs of postural hypotension with palpitations, tachycardia, and dizziness. 15 to 25% blood volume loss. You might have a slight fall, 80 to 100 millimeters hydrogyrum with weakness, tachycardia, and sweating. Where you have 25 to 35% of blood volume loss, you may have a moderate fall, 70 to 80 millimeters hydrogyrum, and then you can see signs of restlessness, pallor, oliguria. Where you have 35 to 50% blood volume loss, there's a marked fall, 50 to 70 millimeter hydrogyrum, and then, the patients may feel, like collapsing, air hunger, and anuria. What are the investigations that, are associated in diagnosis and treatment of PPH? You need to take vital signs as part of clinical assessment and management, radiologic investigations, bedside ultrasound, antenatal ultrasound is indispensable for detection of high-risk patients, with predisposing factors for PPH, such as placenta previa. You have a wide range of laboratory investigations, full blood count to assess anemia. Okay, other, laboratory investigations include coagulation tests. Where you do a coagulation screen, because heavy bleeding can lead to disordered clotting. The coagulation test values prothrombin time at the range 10 to 14 seconds, prothrombin time ratio 1 to 1.2, international normalized ratio 0.8 to 1.1, activated partial thromboplastin clotting time 26 to 40 seconds. So with higher prothrombin time ratio, international normalized ratio, or activated partial thromboplastin clotting times could indicate that the blood takes longer to clot and therefore may predispose the patient to higher risk of bleeding. You need to group, save, and cross-match to enable transfusion of cross-matched blood. Other essential tests will include electrolyte, urea, creatinine, and liver function tests to assess baseline function of kidney and liver. Okay, so you have the range of values that are generally used in my institution. Okay, so remember we talked about primary and secondary postpartum hemorrhage. So in the end, we said in secondary, you have bleeding 24 hours to 12 weeks after delivery. So for management of secondary PPH, other investigations could include screening for sepsis, which could develop from endometritis, blood cultures to establish bacteremia, blood tests, lactate or lactic acid levels, normal levels less than 2 millimole, because the relevance implies that elevated lactate levels indicate lactic acidosis, as seen in cases of hemorrhage, PPH, dehydration, and anemia. Assess C-reactive protein levels, that's the normal range, and it is a hematologic test that indicates the presence of inflammation, such as in septic conditions. So PPH is a risk for sepsis. You can do high vaginal swabs for microbial culture and sensitivity testing, which will inform the choice of antimicrobials. Pelvic ultrasound scan to show evidence for retained products of conception. Okay, so for management of PPH, for treatments may include medications, uterotonics, medications that will stimulate uterine contractions, manual massage of the uterus, to stimulate contraction, removal of placental pieces, examination of the uterus, use of Bakri balloon or Foley catheter to compress the bleeding inside the uterus, packing the uterus with sponges and sterile materials may be an alternative. Tying off bleeding blood vessels, using uterine compression sutures, laparotomy, hysterectomy, rehydration with IV fluids, and replacement of blood loss with blood and blood products to prevent shock, and giving oxygen by mask when required. So early detection and treatment, of PPH can often lead to full recovery. Okay, so we have a table. We just tried to, illustrate what management is about. Okay, and we have, for WHO recommendation includes active management of the third stage of labor. Okay, and that involves administration of oxytocin, 10 IU or 5 to 10 IU intravenously, no earlier than delivery of anterior shoulder, control cord traction, uterine massage after placenta. So if despite active management, there is estimated blood loss greater than or equal to 500 bleeding, greater than or equal to 500 is increased, greater than or equal to 500 mils. Other options include increase it. Sorry, please, I want to enlarge the screen. Okay. Okay, so despite all those things, come back. No, the table. Yes, so in cases where the bleeding continues, despite attempts and interventions, you can initiate resuscitation and then investigation and treatment for postpartum hemorrhage and quantitative measurements of ongoing blood loss. So in the steps, interventions for resuscitation, you can call for help, perform bimanual uterine massage, institute labor unit hemorrhage protocol, deliver oxytocin 20 IU in 1 liter of normal saline, infuse 500 mils over 10 minutes, then 250 mils per hour. Then you have provide oxygen by mass, monitor blood pressure, pulse, and urine output, and consider lab testing, such as grouping and cross-matching, complete blood count. And aftercare includes monitoring for ongoing blood loss, quantitative measurement of blood loss and vital signs, assess for signs of anemia, debrief with and listen to patients and staff regarding their experience with the emergency. Another area of intervention, apart from resuscitation, is to determine the cause and treat using the 4 T's mnemonics. We mentioned tone, we mentioned trauma, tissue, and thrombin. So interventions are based on the cause. So where you find out that the uterus did not contract, you administer oxytocin 20 to 40 IU in 1 liter normal saline, infuse 50 mils over 10 minutes, then 250 mils per hour, administration of carboprost 250 microgram IM, or into the myometrum every 15 to 90 minutes, 2 milligram in total, the use of methyl ergonovine and misoprostol. Okay, misoprostol can be used in doses of 800 to 1,000 microgram rectally or vaginally to treat, for treatments of PPH. In the cases of prevention, is used at the dose of 600 to 800. If it's a case of laceration, you suture and you drain the expanding hematoma and replace inverted uterus. If it's a case of retained placental clot, you inspect, explore, and manual removal of placenta or curettage. If the blood is not clotting, in the case of thrombin, observe clotting, check coagulation studies, replace clotting factors, platelets, and supply fresh frozen plasma. For severe postpartum hemorrhage, transfuse red blood cells, platelets, and clotting factors using the massive transfusion or emergency release protocol. Consult anesthesia, surgery, and an intensivist. Support blood pressure with vasopressors. I want to actually contribute that vasopressors may actually increase, the constriction. So it's used initially just in a case of a patient, that has had a massive blood loss and the blood volume, has really dropped and the blood pressure drops. It's just to increase the blood pressure initially. It's not indicated, for like a prolonged use, or it could worsen the condition. Consider uterine packing, balloon tamponade, vessel embolization or ligation, compression sutures, recombinant factor vita, and hysterectomy. Hysterectomy is usually regarded as a last resort. So here we have a table that shows the drugs that are used in prevention and treatment of postpartum hemorrhage. You have the first line, oxytocin with the dosing. Contraindications, overdose or prolonged use can cause water intoxication and possible hypotension with IV use following CS delivery. Okay, for the second line agents, like the stages we mentioned, carboprost, methyl-legonovine, and misoprostol. So these are, the medication used in prevention and treatment. Cynics, I want us to notice that for carboprost, avoiding patients with asthma or significant renal, hepatic, or cardiac disease. For methyl-legonovine, avoiding hypertensive disorders of pregnancy, including chronic hypertension. Use with caution in patients with human immunodeficiency virus infection who are receiving protease inhibitors. For misoprostol, use with caution in patients with cardiovascular disease. So in this slide, we just want to show an institutional protocol for the management of PPH. One of the recommendations is for institutions to institute a protocol. So these are the steps in a center: admit, take brief history, do bedside analysis, PCV, clotting profile, group and cross-match 4 units of blood. Is a uterus atonic? Massage to induce contractions, examine vulva for lacerations or tears, and repair. Okay, other, like each time, if you notice when we are talking of stage 1, 2, 3, they will tell you to move to the next stage of the institutional protocol. Peradventure, you had used those initial intervention, it did not work. You continue till you are able to achieve a control of the bleeding. So the next stages include, setting up an IV line, administer 40 oxytocin in 1 liter normal saline. Bleeding persists, administer rectal misoprostol 800 to 1000. Bleeding persists if profuse, then hysterectomy is considered. Bleeding plus history and clotting profile results. Tranexamic acid 1 gram to 2 grams that is administered in addition to the drugs above. But I must mention that the use of tranexamic acid is actually indicated within the first 3 hours. After the first 3 hours, it may not be useful. So what are the key recommendations? WHO has continuously promoted active management of the 3rd stage of labor as intervention for prevention of PPH, from the 3rd stage, from the time of delivery of the baby to the birth of the placenta. So that intervention involves administration of a uterotonic drug to make that uterus contract after delivery of the baby, clamping, cutting the umbilical cord, delivery of placenta by control cord traction, followed by uterine massage. Then also, we need to identify low-cost intervention for poor resources to control or treat PPH. Oxytocin is a drug of choice and is routinely administered, okay? And the practice of administration of oxytocin in 3rd stage of labor will decrease risk of PPH and a postpartum maternal hemoglobin lower than 9 grams per day. We must say at this point that if oxytocin is administered at the birth of the right shoulder, it actually helps, in removal of the placenta. But where it is administered after delivery of the placenta, the aim is to, prevent PPH. So those are 2 options. It could be administered, at the delivery of the right shoulder, or it could be administered, after the delivery of the placenta. So part of the recommendations include, the use of misoprostol, and it is inexpensive. It doesn't require parenteral administration. It's more effective than placebo in PPH. But we must say at this point that the use of oxytocin is superior to misoprostol, in treatment of PPH, okay, in treatment and in prevention. Also, misoprostol is associated with more side effects like nausea, diarrhea, and fever within 3 hours. But in women with PPH, tranexamic acid, given within the first 3 hours after birth, reduces mortality due to bleeding, but not overall mortality. Again, a key recommendation is to avoid routine episiotomy, okay, unless urgent delivery is necessary, and perineum is thought to be a limiting factor. So we also need to institute massive transfusion protocols to avoid complication of dilutional coagulopathy and PPH. interdisciplinary team training and simulation, are key to improve perinatal safety. Okay, so when we want to model the practice for farm care in postpartum hemorrhage, we have to take into consideration for the clinical pharmacists, these steps are actually important. Okay, and so these are the steps that we are talking about. We are talking about history taking, assessment, identify patient-specific needs, educate, create awareness, treat PPH with appropriate medication, engage collaborative teams, a collaborative team-based approach in management, monitor patients to prevent and detect, disease progression, assess, treat, and prevent, complication. Other things that we need to do include ensuring timely supply of medication. Medications for low resource setting should be suited to the community and expertise required. Ensure follow-up and referrals where it is necessary. Why we are talking of follow-up and referrals, for like cases of severe, PPH, most times, there are complications which are, often ignored, like in the process of trying to save the life of the woman or the baby, other times, other conditions like assessment of mental status, follow-up monitoring, quality of life assessment, they are not done. So the clinical pharmacist, is really in a position to ensure this follow-up and then institute appropriate referrals where it is necessary. It is important to document and report cases of PPH in the community. And we want to advocate in this meeting that the use of misoprostol for in PPH is an appropriate choice for community-level prophylaxis of PPH. Patients' lives can be saved if the clinical pharmacist is educated to advocates for, all the traditional birth attendants, liaise, all the people that take home deliveries, advocates for the use of PPH in those deliveries. Patient education is necessary, so we should advocate among auxiliary midwives for misoprostol use in community practice. In conclusion, we want to say that postpartum hemorrhage is one of the leading causes of maternal mortality and morbidity globally. There are inaccurate blood loss estimations, poor documentation, and underreporting of cases of PPH in low-income countries like Africa, which limits accurate diagnosis and treatment. To improve diagnosis and treatment, clinical pharmacists need to be involved in collaborative team engagement for postpartum hemorrhage. To improve public health, educate the public and engage relevant stakeholders in policy making and drug funding targeted at managing the condition. These are references, thank you, from all of us, but we have a case, that we want to, we have a case study that we wanted to, to illustrate this presentation. Please just hold on a bit. Let's post the case study.
Hello? Hello?
Okay. And we are trying to post the case study.
Okay.
Case of PPH. Case of PPH. Case of PPH.
Please, can you start the case study? Why the uploading the slides, please? After 10, please.
Okay, so we have a case of primary postpartum hemorrhage secondary to retained placenta. We have patient EOE, an 18-year-old student who presented to our facility on account of body weakness for 8 hours, vaginal bleeding for 6 hours, history of present illness. She's a teenager who delivered through spontaneous vaginal delivery 8 hours prior to presentation. Baby was carried to term. Outcome was a live meal with an unknown weight. Okay, the delivery was taken by a traditional birth. The delivery was taken by traditional birth attendants, and placenta was retained after delivery, resulting in severe bleeding. Quantity of blood clots could not be ascertained, and bleeding persisted, resulting in body weakness. Though bleeding stopped prior to presentation, there was associated generalized body weakness and dizziness without loss of consciousness. Patient is not a known head, no history of transfusion, surgery, or previous hospitalization, not a known PUD patient, no history of STI or vaginal infection. She was not on any routine medication and had no known drug allergy. Patient is not married and does not live with partner. She has no known family history, of health. She takes alcohol moderately and does not smoke. Okay, and no family history of similar condition, no known family allergy, O and G history. Patient has no history of menorrhagia, dysmenorrhea, or termination of pregnancy. She attained menarche at 12 years old, 28-day cycle with 7 days duration. She's gravida 2, para 2 alive. Index pregnancy was undesired and spontaneously conceived. All her pregnancies have been unbooked. All her pregnancies have been unbooked and delivered by TBA. First pregnancy was uneventful. Patient is aware of pap smear, but aware of contraception and uses condoms and takes pills. Physical examination. She was a febrile pale plus with generalized body weakness without pedal edema. CVS chest examination showed blood pressure 110/60 millimeters hydrogyrum, pulse rate 136 beats per minute. Okay, respiratory rate 27 cycles per minute. She was severely anemic with PCV of 15%. A cord was seen extending from uterus with the end tied with a dirty rag on vaginal exam. There were no assessed abnormalities in other organs. Okay, an assessment of PPH, primary PPH, secondary to retained placenta was made. Patient was admitted to level 1 with request for urgent PCV, EUCR, grouping and cross-matching of 2 units of blood for transfusion. The following medications were ordered: oxytocin, IVC Pro, metronidazole, antibiotics, and she was prepared for manual removal of placenta in theater and transfused 2 units of blood. At that point, she has stage 4 of BPH. On day 1 post-admission, patients are not procured administration. First day after admission, and BP was 90/60 and deteriorated. Vaginal examination showed 2 vulvar pads soaked with normal lochia. She was transfused another 2 units of blood, and then IV, normal saline, 50 mils over 30 minutes. She was also encouraged to procure her administration. On day 2, after manual removal, after she retained placenta was manually removed under anesthesia, patient became severely pale, plus, febrile 38 degrees Celsius. Diastolic BP had dropped further, reduced to 90/45 millimeters hydrogyron. She was to be transfused another 2 pints of blood and prescribed ceftriaxone, metronidazole, paracetamol, ferrous sulfate, folic acid, and then vitamin C and vitamin B complex. On day 3, she complained of pain and diclofenac was administered. It was added to her medications. On day 5, patient became stable and started recovering. Her post-transfusion PCV improved to 33%, and she was discharged home with tablet diclofenac, cefizime, metronidazole, and the already prescribed, hematinics. So this is a pharmacist assessment where it was deduced that the rationale for drugs use were appropriate, and she was advised on the need to book for antenatal care in future and to desist from using a TBA, as she would be better taken care of in a hospital or primary health center. The care goals were to correct anemia, improve quality of life, reduce hospital stay, and increase patient tolerance. The care plan ensured appropriateness and adherence to prescribed medication, encouraged patients and caregiver to do all requested lab investigation, educated patients on her medical condition, emphasizing on the need for antenatal care while discouraging her from patronizing TBAs and unhealthy birth practices. Clinical outcome was good. Patient was able to procure her medication and was able to carry out all investigation. Humanistic outcome was good because patient was satisfied with the level of care which was provided. So at this point, I want to say thank you very much from all the members of our team. We have come to the end of the presentation. Thank you. Hello.
Wow. Thank you very much, Dr. Ruth Orebi, for that wonderful presentation. I think she deserves an applause. She has done very well. She and her team members were able to highlight important aspects of postpartum hemorrhagic events. And she started by defining what PPHE is, to tell us how it presents. She now went on to talk about the investigations, laboratory investigations, and biologic investigations. She now went on to talk about management protocols. She now narrowed it down to the practice in University of Uyo Teaching Hospital. Then she now ended up by bringing up a case of primary postpartum hemorrhage, secondary to retained placenta that was seen and managed in the University of Uyo Teaching Hospital. I think it's a very interesting presentation, and I've learned quite a number of things today, and I'm sure that majority of the people who have joined this meeting have also learned something new. So well done, Dr. Rebi. Thank you for this very insightful presentation. So I don't know if anybody has a question to ask or an addition to make, because we are all here to learn. Okay, I've seen one hand up. Pharmacist Umujekwe Ogu. I think we can allow you to speak.
Okay, thank you very much for this wonderful presentation. So I have just a few comments to make. The gold standard now for the treatment of management and treatment of PPH is now tranexamic acid. Before now, that was in 2012, when it was only used when other uterotonics failed. There was a research that was carried out at that particular time. So, and they found out that there was really it didn't supersede the uterotonics. So then it was only used when it failed. So, but in 2017, there was a recent study, the World Antifibrinolytic Study, was carried out that year. And at the end of the day, it came out as the gold standard for the treatment and prevention of PPH. But I found out that most of our settings, they don't usually use it. I don't know why. In fact, I actually carried out a research on it, why the doctors were not really using it. But we have to know that it's been superseded. The uterotonics have been superseded in as the gold standard. The gold standard now is the use of tranexamic acid, unless if the patients have thrombolytic events, they won't be used. But the gold standard by WHO now, since after that 2017 study, is to use tranexamic acid. In fact, they went about to also advocate that in all obstetrics and gynecologic units, it should be present there to be used. So we have to also know about this. Thank you very much.
Okay, I'd love to comment on that. When we were doing the research on PPH, tranexamic acid is actually mentioned, but the first line is oxytocin. And the use of tranexamic acid is purported to be of no benefit after 3 hours. So essentially, if you want to make an intervention where you use tranexamic acid as the agent, it must be instituted within the first 3 hours of bleeding. After the first 3 hours, is not seen to be of any clinical benefit to the patient that you are administering it to. So the hour of administration is key, according to the WHO key recommendation. It must be administered within the first 3 hours. Like you said, yes, even in our center, it's not readily used. There are some specific patients, that is used for. So it's not for like every patient, it's not a deal. Then if you notice that table of the management, they had mentioned if you have bleeding up to a certain number of mils, apart from resuscitation, ideally you must identify the cause and treat. That's why you have the 4 T's. So identify under which T does it fall under, and you treat the cause and you stop the bleeding. So that table is a very quick guide to help you to rationalize and know what to do for the patient for that particular bleeding episode. Thank you very much for the contribution. Hello.
Thank you, Dr. Rebi, for responding. I'm sure the question has been properly addressed.
Yeah, well,
I don't know if, okay, the hand up here.
These are guidelines that we should follow, as clinical pharmacists. So yes, that doesn't make it not to be the gold standard. So we should know the gold standard. Other uterotonics, before now it was if they failed, that's when you use tranexamic. But with this woman trial, it's now said that it's the gold standard for all the centers to be used. So let's just have it at the back of our mind that tranexamic acid is the gold standard and not uterotonics. Thank you very much.
Thank you very much for that contribution. I have another one up here, that is DAE. I don't know, that's an initial. But please, you have the floor. You can ask your question or make your comments.
Okay.
DAE.
Yeah, good evening. That was a very brilliant presentation. Thank you for that. Mine is not really a question because the slides, I couldn't even get anything from the slides. So please, if you could send the slides across, maybe on the platform, that's the WhatsApp group, we really appreciate it.
Yes, Sipan Akwa Ibom State Secretary will post the slides after the meeting.
All right, thank you.
Okay, we'll do that. We apologize for that. We will share it immediately after this presentation. We have a third hand up here, and that's okay, yeah, from our national vice chairman, Dr. Maureen Wafo. Please, ma'am, you have the floor.
Okay, thank you, everyone. Good evening, everyone, once again.
Good evening.
I want to, thank you, our dear presenter. Very good work indeed. I want to thank your theme also. We are really practiced as clinical pharmacists. I just have a question to ask. Based on your presentation, you mentioned several complications that always arise when there is a PPH, and one of them is the DIC. So I want to ask, how do you people manage DIC in your center? And do you people have what you use to measure clotting profile at the patient bedside or at the general labs? Because I know that time is of essence. So that's my two questions. Thank you.
Okay, actually in my center, we don't have that clotting bedside profile. We have a general lab where the blood samples are taken to, but it always comes out and the results must be seen before the patient is taken into the theater so that they will prepare for, eventualities. Then for the protocol to like treat DIC, I did not get it for this meeting, but we're told, that there are some, steps which are taken to like treat or prevent massive hemorrhaging events in the case of DIC. But if I may remember a case we saw some years back where there was an assessment. What was done for the patient was hysterectomy, which is like a final resort because she kept on bleeding and they couldn't stop. So I think what they eventually did for her then was hysterectomy to save her life.
More trouble for Naramali as court issues production warrants to answer.
That's how far I can remember for that case that we saw in the clinic.
Filed by the EFCC.
I don't know if you have any contribution about the management of DIC.
The states discusses the petitions by the candidates.
Hello.
BC and the PDP.
Hello, Dr. Mori.
Do
you
have noisy background?
Hello.
I'm here. Just that the background is very noisy. Don't know who is talking. Okay, for me, I work in ICU.
Okay.
So, development program, the UNDP.
Would you have such patients?
Please, can you mute?
Adamawa and Borno states in returning all internally displaced persons.
Dr. Ise, please mute the speaker.
Under the Solution Agenda program. The head of the UNDP in Nigeria, Mr. Mohammed Yahya, made this known while on a courtesy visit to Governor May Malabuni of Yobe State at the government house.
Dr. Ise, please mute the speaker now.
He explains that.
Okay. Okay, for me, I work in ICU, and from the theater, they do bring in such patients to the ICU. Whether they have
Okay, ma'am, I see network problem.
Okay, sorry. Am I like I muted myself?
You can speak. We are listening to you.
Okay, I said for me, I work in ICU. So such patients do come into the ICU from the theater or even from the labor room. They do come in with a hypotension. DIC, sometimes they even wait to HELP syndrome with their compromised liver and their kidneys, you know. So such patients for DIC, we pharmacists will make sure they're not on anticoagulation therapy. That's why, because you see them bleeding through their nose, through their ears, and all sorts not. But that PTI now, the clotting profile is of essence at the patient base, because we continue to check the prothrombin time, the INR, as we manage with a fresh frozen plasma to help to bring up the clotting profile of such patients. While we continue to give in inotropes, to help to bring up the blood pressure. After they must have transfused, they must have transfused the blood, fresh frozen plasma, whole blood, and the normal saline. So continue to. So the most important for clinical pharmacists to be at such patient bedside, see what is happening, know how to read the PT-INR, see how it's appreciates, know when to, at a time, because such patients are, they don't move, so we don't continue to withdraw anticoagulation for a long time. So we continue to monitor and know when there is abated, hemorrhagic abated, and know when to initiate anticoagulation back. So it's a multidisciplinary team approach, but clinical pharmacists' input is very, very crucial at that point in time. So because we've had a case, DIC was queried, but the patient was sort of on anticoagulation. If you can imagine that, it's just the clinical pharmacist that make sure that it was stopped. At the point, the ONG team was saying, we can't just remove it. Can we initiate heparin? Can we do this, that? So at the point, I have to go and call the hematologist. And she came in and stopped all those things. So it's of essence that we understand PPH, the complications, and how to manage such as the case arises. Thank you for your beautiful presentation.
Okay, thank you very much, Dr. Mori, for that very insightful contribution. I don't know if there is any other person that has a question or a comment to make. Yeah, let me ask my question. My question is on the risk factors for postpartum hemorrhage. Are there risk factors? I didn't see that you didn't mention them. Or I hope I didn't miss it. Hello, ma, Dr. Ruby. Hello.
Sorry, I was muted. Yes, I did mention the place I talked of etiology. The risk predisposed to the risk and the causes. Remember, I mentioned them 40s and others. So all those things that I mentioned under, anemia, placenta previa, all those things are more like risk. Even sepsis has been included as one of the risk, and I mentioned something under others. I think I mentioned Asian origin. And in the literature that we studied, it was mentioned that it's not really about the physique of the Asian populace, but more like it has to reflect on the quality of care of the skilled personnel who take deliveries in those areas that actually impacts or increases the risk for PPH. So all those things that we talked, the risk and the causes are more or less related and reflect, or impact upon, increasing risk of exposure for PPH in the postnatal or antenatal women.
All right, thank you very much. But I noticed that in management, most of the cases, there is usually the use of antibiotics. I don't know, does it help stop the bleeding, or what's the justification for the use of antibiotics? I think in this era of antimicrobial stewardship.
No, it's not every case that has antibiotic indicated. If there is an assessment, maybe of an unhygienic environment that the patient was delivered in, or there's a high suspicion for sepsis, like you see in this case of the primary postpartum hemorrhage, secondary to retained placenta, she actually came in with a dirty cloth tied to the umbilical cord. And then, even though, she did not have fever, she had some other signs which proved that something, was like happening. So at that point, you can do an MCS, you take samples and then wait for the results to come out to know actually the antibiotic or the antimicrobial to use. But you can, based on empirical knowledge, you could use a particular antibiotic which has been found useful in that region. So it's not that every patient will come and while treating PPH, you just slam the person with antimicrobial, not at all. It's based on the assessment, on presentation.
Thank you for that clarification. I want to be sure that it's not not in all cases that we have to use antimicrobial. So I don't know if any other person has any comment to make. And the case that you presented today is, I think it came from traditional pet attendants. I don't know, as pharmacists, because the number of cases that come from TBM is usually very near death situations. I don't know how, as healthcare providers, we can help in the society get out of this very unfortunate situation, because it goes beyond even very enlightened people. I've seen quite a number of them that still patronize traditional pet attendants. So it goes beyond health education. I think it has to do with religious beliefs and so many things. So I don't know if, as pharmacists, we can help in curbing the level of patronage of TBAs, because, or should we take the enlightenment to them? That could be another angle where we can kind of train them when they should refer. Because if you say you want to stop it in this part of the world, it's going to be very difficult. So we can take the training to them. If they see people that are at risk of coming down with PPH, you should refer. I don't know if that would be a good option.
Yes, it's a good option, because a lot of people are not well informed. So education, awareness, enlightenment, advocacy are very, very important. In January, the O&G team went, into the community, and we were involved in education and awareness campaigns against PPH. We had a dialogue with one famous TBA around that hospital environment. But you know that, again, what really influences the choice of people going to TBA is that religion aspect. Religion, some will tell you funding, some have some fears. Maybe they think they'll end up in CS and all that, and they go to these places. So, but if we don't engage these TBAs, they will not be properly educated to know when to refer. You have cases that they allow the woman to bleed and bleed. Then at the point of seeing she's about to give up, they'll just move and the person dies on arrival or before entering, all those things. So we must engage in advocacy and education strategies. And it's a team-based approach. Even as we talk with other healthcare professionals, we should also get them involved so that everybody can contribute and wage the war against this menace. I can see August's hand up. I think she has a contribution.
Okay.
Okay, yes. Yeah.
Okay, that's okay. I want to talk about the TBAs now. So you find out that in this part of the world where we are, you'll always see the poor around us. Whether I want to believe it or not, there are always people that cannot afford the hospital, fees and all that. So they will always patronize the TBAs. So advocacy now is that WHO is trying to train the TBAs so that they'll be able to attend to these patients that come to them. They'll have the basic requirements that they need, so that and also they train them to also refer. So in that way, even those of them that cannot afford the hospitals, they'll have to go there to seek care. At the end of the day, they'll be able to get the full benefits. And when there's a serious case, they'll refer to the hospital. They'll tell them to refer. So WHO is trying their best to make sure that they train all those TBAs so that they will be knowledgeable about what to do, and especially third stage of labor and all that, to avoid this maternal mortality. Thank you.
Well, thank you very much for that contribution. I think that's certainly the way forward, because if we say we are going to take them out, I don't think it's possible.
Yeah.
It's we're telling ourselves a very big lie.
Yeah. Yes.
So I don't know if there's any other person else. I think if we have all, there's nobody that wants to speak again. So I don't know if there's any we can take our closing remarks. Looking for Dr. Regina James here. She's here. The CPAN coordinator of Akwa Ibom State. Okay, she's not here. Okay.
She was here. I saw her some.
Okay.
She has been knocked out. Maybe she's been knocked out. I don't know.
Okay. So, okay.
And Dr. Nwanudo.
Nwanudo is here. Okay, let's recognize her. Ma, you have any comment to make?
Let me unmute myself.
Okay, ma.
I hope you heard me. I've done my comment. Okay, thank you very, very much.
Oh, we didn't hear you.
Okay, I'm sorry. I had spoken, but I can repeat myself. I just want to say good night or good evening to every one of us. And I want to appreciate the presenter. I've already dropped my own reaction on the chat box that I enjoyed the presentation. It was very interesting and intelligently delivered. And I want to congratulate the team for the work that you guys are doing, especially in the teaching hospitals and other specialist centers. Thank you very much. Good night. Can you hear me? I finished. Good night.
Yes, we have heard you. Thank you very much, ma, for that encouragement. Yeah. So our national chairman is not here, but we have our vice national chairman of CPAN. So I think she will take the closing remarks before we take the closing prayer.
Okay, thank you very much once again. And on behalf of our national chairman, Dr. Joseph Madu, I want to congratulate Akwa Ibom CPAN for a very good work you put in this night. My special thanks go to the team, the presenter has herself, for presenting this warming, educative topic to us. Thank you so much. I want to thank our dear moderator, Dr. Eshet. Wow, I'm not surprised what you can do. Thank you once again. I want to appreciate all members who have been on since almost 2 good hours now. Thank you for joining us. And I pray that next week, Friday again, we all have to be here again to continue to learn. And I pray that we'll put all we've learned into practice to improve our patients' outcomes. Thank you very much.
Well, thank you very much, ma. for that word of encouragement. Can we have our closing and prayers? And I will call on, very respectfully call on. Okay, Dr. Ronai Charles is no longer here. I saw him a moment ago. So let me call on pharmacist and Lower to Grace to please help us with the closing prayer.
Okay, let's pray. Heavenly Father, we thank you for the opportunity we have to have this clinical meeting. We've learned a lot and we'll continue to teach one of us and let us have a good night rest. Guide us and protect all of us in the name of our Lord, in the name of our Heavenly Father, Jesus Christ.
Amen.
Amen. Amen.
Thank you, everybody.
Much.
Thank you so much.
Thank
Thank you
you.
very much.
Thank
Good
you for
night.
attending. Good
Good
night.
night.
God bless.
Good night.
Good night, too.
Good night,
Good
ma. Good
night,
night, ma.
ma.
Good night, everyone.
Good night,
Good
everybody.
Ruth, well done. Good night.
Good night, everyone. Good night. Sweet dreams.